My name is Sarah Zanton. I'm the Dean of the Johns Hopkins School of Nursing, where we're educating the nursing workforce of the future to be prepared, to support community-based and advanced primary care. It's my great pleasure to introduce a true champion for better health in America, Senator Sheldon Whitehouse. Senator Whitehouse is a tireless advocate for strengthening primary care, which, as we know, is the essential foundation of our health system. He understands that investing in primary care means healthier communities, fewer emergency visits, and better outcomes for all. Whether it's pushing for value-based care or working to ensure primary care providers have the support they need, Senator Whitehouse has consistently put patients and public health first. What's even more inspiring is how he's brought that same commitment to bipartisan collaboration. In today's divided political climate, it's really refreshing to see real cooperation, and that's exactly what we're seeing in his work with Senator Bill Cassidy. Together, they've introduced forward-thinking legislation that aims to stabilize and strengthen primary care nationwide, the Pay PCPs Act. Legislation to better support and improve pay for high-quality primary care providers. It's not just good policy, it's a model of how lawmakers can come together to tackle tough problems with practical solutions. Please join me in welcoming a principled, pragmatic voice for primary care reform, Senator Sheldon Whitehouse.
Thank you, Sarah. You get the alliteration award for all those P's in that last sentence. And you're all probably wondering what the hell a lawyer is doing butting into healthcare. I started in on this years ago when Crossing the Quality Chasm and To Err is Human first came out and focused on how savings were possible if we could improve quality and diminish errors in our healthcare system. And so it's been a long journey since then, which included founding the Quality Institute in Rhode Island, which has been very helpful at trying to bring people together around quality improvements and payments and so forth. And then, of course, in my legislative work, I've kept at it. One of the things that motivates me a lot is that we are running huge budget deficits that are adding up to our unconstrained national debt right now. And if you look at our federal healthcare spending, that's a big part of the problem. The United States is a wild outlier from all other developed nations in terms of how much we spend per capita on healthcare and how poorly we do in terms of one really basic measure of success, which is life expectancy. 17+% of GDP in the US goes to healthcare. Compare Germany, 12.5%. If we got to Germany level, and by the way, healthcare is pretty good in Germany. If we got to 12.5% Germany levels, we'd have saved $1 trillion a year in healthcare. So really important to try to get there. By the way, our life expectancy compares to Estonia. So considering what we all do and what you all do to keep Americans healthy, there's obviously enormous room for improvement. So I've been working on where do you find those room for improvement opportunities. And one, obviously, is moving more and more towards primary care, which is the least expensive and most efficient and most effective and welcome means of delivering care. We have not been running in a great direction in this country. We've gone from 6.5% of our healthcare spend for primary care in 2002 down to 4.7% of our healthcare spend for primary care in 2019. In Rhode Island, we chose a rather different path. We set up a health insurance commissioner. I helped write the statute that created that position. And our health insurance commissioner, who some of you may know at the time, was Chris Kohler, who's still very active in the reform space. And he set about requiring insurers to raise their primary care spend every single year by 1% until we hit 10.7%. Now, 10.7% still doesn't seem like a very big number, but compared to 4.7%, it is a big improvement, and it's my belief, not particularly well peer-reviewed and proven, but it's my belief that raising that spend lowers costs at the end of the day. So that's one avenue to get where we're going. The other avenue to get where we're going is to get off of fee-for-service as well as we can. And we had 3 ACO. I worked very hard to get ACOs into the Affordable Care Act. And then I worked very hard to defend the ACOs from the Biden administration's efforts to loot and pillage them before they could get their feet grounded underneath them. And the result has been, I think, a pretty good outcome overall, in which the ACOs weren't being stripped bare of all their savings right away and had a chance to actually prosper doing what they were doing. I used to argue that they were starving the lead dogs, and that's a very poor way to encourage entities to become lead dogs. So the ACOs are out there. They've kind of crested at this point. I think we need to move on to next steps. The problem from our ACOs that I heard over and over again is they still have to run the fee-for-service system with all of its administrative cost, and they have to run the MSSP savings system side by side. So we've actually doubled the administrative burden, and the result has been pretty good. We have actually reduced costs. Our ACOs in Rhode Island cover, I think, 39,000 patients in a given year, and they got $11 million in savings. So it's gone very well. My favorite stories are about going to the frequent flyers in the emergency room and sending out a social worker and figuring out what they're doing there. And one of those stories came back that, boss, this is going to sound crazy, but I think if we buy this guy an air conditioner and a TV, he'll get out of our emergency rooms. He's there mostly because he's hot and lonely. So for $800 at Walmart, they got an air conditioner and a television and installed it in his apartment. And sure enough, he went from a $220,000 annual spend to a $30,000 annual spend, which is pretty good payback on $800. Plus, it signaled that they were meeting patients where they are. And you could never, ever, ever do that with a benefit structure. You could never make a TV a benefit. You could never make an air conditioner a benefit. But what you can do is free up doctors to make the right decisions for patients and share in the benefit of improved health and go wherever that is. If that's a sticky pad under the rug at the bottom of the stairs, great. If it's telehealth machinery in the bathroom at home, great. If it's an air conditioner and a television, great. Whatever works. And it really, really has worked. So where do we go going forward? Well, there's the AHEAD program, which Rhode Island is applying to. I get early signals that the Trump administration is not going to kill that off, and I think that provides a lot of potential. Bill Cassidy and I also have the bill for primary care improvements, which goes to a hybrid payment system where you don't have to have a foot in both the fee-for-service and the value-based care boats. You can lift half of your foot from fee-for-service and have a part of the business run off of a pure, predictive, per member per month value-based model. And that's a step towards finally being free of fee-for-service for once and for damned all, because fee-for-service, I think, has been dreadful in its effects in the healthcare system. One of the little bonuses that we're going to get out of this, if I can make this work, is that we will also get rid of prior authorizations, at least for doctors who are in a value-based care model. One can argue that prior authorization makes sense in a fee-for-service model because it puts a control on people who are hypercharging the fee-for-service model to just run the numbers and run the bills. But as soon as the practice is equally invested with the payer in reducing cost and improving care, the logic for prior authorization evaporates and it is left exposed for what it too often is, which is an excuse financially to delay payment and keep revenue in the insurance company's pockets until a later day. And in addition, everybody who's in the medical practice, who's involved in fighting through prior authorizations, is a deadweight loss on the healthcare system in terms of just the expense of having to run and manage that. So I think we've got some pretty good direction. I would reassure all of you that even in the darkest days of polarization around repeal Obamacare, nobody came after the ACOs. The value-based care model is very well understood. The two doctors on the Republican side, Cassidy and Barrasso, are both allies of mine in various angles of trying to repair this. So despite what you're seeing in terms of polarization in Washington, do understand that this remains a quite open lane for further improvement, and things like the AHEAD model and hybrid payments and eliminating prior authorization, I think, can all move the model forward in ways that are very helpful to all. Two things in closing. One, in Rhode Island, we love what happened when the ACOs stood up. Patients could not have been happier. Morale soared. To a certain extent, doctor morale soared as well, but it's in a very, very challenging environment. So I thank you all for persisting through that challenging environment, whether it was the difficulties of getting through COVID with plenty of chloroquine or whatever the hell they called it, and the difficulties of getting through what is happening now in our healthcare system, both in research and potential reimbursements to Medicaid and all of that. I don't know what's going to happen with Medicaid. On the one hand, in their actuality, they put an $880 billion target on Medicaid's back and instructed a committee to go find those savings, which can find it nowhere else but Medicaid. So that's pretty clear targeting. On the other hand, when we tried to get them to undo that in amendments on the floor and moved amendments that they would not cut Medicaid benefits, they said, this is an unnecessary amendment, so we're going to vote against it because we have no intention of cutting Medicaid benefits. All right, we'll explain the $880 billion law you passed. So somewhere between those two is where they're going to land. In my state, at least, if Medicaid takes a serious hit of any kind, it risks collapsing the entire healthcare system. It means Women and Infants Hospital can no longer afford to operate because so many, 44% of births are covered by Medicaid. It means that nursing homes collapse because 66% of nursing home revenue comes through Medicaid. And even if your auntie is not on Medicaid, when that nursing home closes its doors because it's gone bust, that's her problem too, as well as the Medicaid recipients. And I've long worked to improve the care and the resources available to people in what I call the long and noble road to recovery. And folks who are in recovery programs for addictions are enormously often dependent on Medicaid, so they all get thrown to the wolves again. So there are lots of reasons to make sure that that does not happen, and I would encourage you to go through your little contacts in your little machine, and anybody you know who lives in Maine, Pennsylvania, Florida, Ohio, where there's a Republican senator, ask them to make a call to that senator's office and say, hey, knock it off with the Medicaid. Here's what's going to happen to us. By the way, I'm a nurse. I know what I'm talking about. I'm a doctor. I know what I'm talking about. I'm a healthcare professional. I know what I'm talking about. And get them to send that message, because those messages pouring in are causing real second thoughts to happen in the minds of our Republican colleagues, and we need to keep that pressure on hard now in the next few weeks as they try to sort through this problem. So with that, I'm getting the sign, 2 minutes left, and I'm kind of wrapped. So I'll take a quick question if anybody has one or a comment. Yeah.
What is the status of Obamacare nationwide and in your state? Because I have heard that they want to try to kill it again.
Yeah, we'll have to see how that, whether they, we did it by reconciliation. They can undo it by reconciliation. And we'll just have to see where that goes. At the moment, there are so many places in which people are getting health coverage through the Obamacare program that it really will cause a lot of human trauma and sorrow and financial grief if they do it. So I think what they'll probably do is look at narrower targets, do things like say, well, you can have it, but only if you're, not if you're able-bodied, which is great until somebody's there for like addiction services or mental health services. You can be able-bodied and still pretty damn sick. Or to go after the Medicaid expansion, because the Medicaid expansion happened more in blue states than in red states. Or if they really wanted to play rough, just name the states where they're going to get rid of Medicaid expansion and have it be all the blue states. So I think it's going to be that kind of shot at the margins of it rather than an arrow to the heart of it that's going to be their target. They're on thin ice right now politically because of you-know-who's nutty behavior and how things are piling up around the tariffs and all of that. And I think the Medicaid and Obamacare dangers are becoming much realer to them.
Well, doesn't it supposed to be that red states has also tons of people?
The highest participation in Medicaid and in other federal programs is in red states like Mississippi, for instance.
So why they want
Go ask them. I don't have an answer to that. That's part of why the pressure is on them, because, you know, their constituents are going to pay, going to suffer. Yeah.
Thank you, Senator Whitehouse. Dr. Rosish, I'm actually a pulmonary care and sleep physician. You find that you mentioned Germany as an example, as a comparison to the U.S.
Yeah.
So
Or you could pick any developed country.
Yeah.
I picked that one.
Yeah. I mean, so I was trained in Europe, and coming over here was kind of a big shock, you know, and like what's provided and how much it costs
Yeah.
to the patient. And so my question would be, if you would have the power to like rebuild, I mean, I know this is not, probably the answer is not, doesn't fit into like 20 seconds to
Yeah.
be overarching, but how would you, how would you do that, and where would primary care be in that vision?
I would probably try to move to a Medicare for all type model where coverage was universal, but continuing to allow the Medicare Advantage programs to compete with each other in the Medicare space. So it's not one giant leap. That also allows private entities like major corporations that have their own healthcare program that they want to help deliver for their employees through a known provider to be able to stay with a Medicare Advantage company and deal with them. I think in terms of making a move away from where we are right now, that is probably the best step, and then we sit and watch and see how that works and what we can do to clean up some of the Medicare Advantage problems, and then if we need to go further, we can go further. But I think that's the first step. Whatever we do, we have to get rid of fee-for-service. Just has to go. If I were building a house, the idea that I would go to hire my contractor, read my primary care provider, the person I know and trust who's in charge of my health, and then let every single specialist, the tile people, the plumbing people, the electrical people, the roofers, all bill me directly and not run it through the general contractor. The more we can make primary care the general contractors of healthcare so that they have more sway over what specialist services are provided and how and when and all of that, I think we end up in a good direction that way too. So those are the three kind of general purposes that my legislation has been pointing towards. Yeah, one last and then I'll be out of your hair.
Thank you, Senator.
Yeah.
So I grew up in Rhode Island.
Good for you. Where?
Barrington.
Barrington, good. Bedroom community for professionals, very nice place. Soon to be underwater thanks to sea level rise.
So as I'm sure you're aware, a major primary care medical group, Anchor Medical, is closing in Rhode Island.
Yep.
25,000 people from the province colonel losing their primary care, including some of my family members.
Yep.
Given the attention that Rhode Island has tried to pay to improving primary care situation, how do you diagnose what happened with Anchor and how to avoid things like that? in Rhode Island and other places?
Reimbursement levels, plain and simple. Rhode Island is in a regional market in every possible way. The guy who drives me around had a cancer incident, got his care up in Boston, commuted up and down. We have schools that move people out into the healthcare field in various ways, and they don't go to Rhode Island, they go into the region, wherever. Connecticut is paid about 20 cents more per dollar than Rhode Island is. Massachusetts, about 22 cents more, as I recall. St. Anne's Hospital, for instance, is in Fall River, a golf shot from the Rhode Island border, and 30 minutes by road from Rhode Island Hospital, which is a teaching hospital, which provides top-level trauma care, which has all sorts of specialties in cancer and brain illnesses, and it's a very, very terrific first-rate operation. St. Anne's is a perfectly nice local hospital, but it doesn't compete in that sense. It simply doesn't offer the services. And yet, they get paid 20% more than the Rhode Island doctors. And that has really slaughtered primary care in particular. So if we can't make up the unfair difference in the CMS payment that singles out Rhode Island between these other two states in a common region and screws us, then the legislature is going to have to spend more money. And a piece just went into the governor's budget of a starter $5 million, which isn't that much, but at least it's a nod towards understanding that you can't live in a regional market for healthcare with a 20+% differential between you and the hospital right across the border. That's our problem, and that has to be solved. Thank you all very much. Best wishes. Good to have you here working on these issues and thinking about them. And if you have good ideas, don't hesitate to let me know. Thank you.